All right, all right, here we go. So we left off, right now we're covering some of the basic surface anatomy, okay, of the cerebrum and the brainstem. We finished the cerebrum. We did the front part of the brainstem, right? And talked about, we left off that last slide before was the cranial nerves. We just, showed you where those generally are. Now we're going to look at the back part of the brainstem, and then we'll get into a little bit of cerebellum, the spinal cord, and then finish up. So looking at the backside of the brainstem, there's a few important structures to consider here. So the first are these things called the superior and inferior colliculi. So these structure here and here, that's the superior colliculi. And then these bumps here, just below it, are the inferior colliculi. There's a little structure here that you don't have to know, but I'm just kind of pointing it out. There's like a little ridge there. That's called the brachium, or the arm of the inferior colliculus. Okay. So, and that's actually, it's interesting. So this is actually your thalamus that sits off right here. And there's a couple bumps on the back part of your thalamus right here. One of these is the lateral geniculate nucleus, which is associated with vision. And this one here, actually this is the lateral, I'm sorry, this is the medial geniculate, lateral geniculate nucleus here. But the brachium of the inferior colliculus takes some information. This is some reflex information regarding hearing. When sound comes into your, into your system, some of it goes to the cortex for conscious awareness, but some of it actually goes into the brainstem. And so when you have a reflex, you look to the side when somebody makes a loud noise or something like that. It's hard to to not look when something makes a loud noise near you. It's a reflex. That inferior colliculus mediates some of that reflex, and it has connections with some more primitive motor pathways in your upper neck and upper shoulders and neck to make you look towards that sound. But some of that information also is carried then up into the thalamus through that brachium of the inferior colliculus. The superior colliculus is a similar function but with vision. So it's a center that is associated with reflex, like visual deviation of your eyes towards something. You see something in your periphery, some object moving, and you kind of make that reflex movement even before you've made full conscious awareness of what that object is. But the inferior colliculus plays a role in the circuitry within the brainstem to coordinate that eye movement with your oculomotor nerve and all that stuff. So superior colliculus, and I think about kind of my eyes being a little higher than my ears, so that's kind of how I remember the superior colliculus are more associated with reflexive eye movements, and that the inferior colliculus are more related to the hearing, reflexive movements associated with hearing. Okay, so that's the inferior and superior colliculus. Some people refer to this whole region in textbooks as the corpora quadrigemina. Corpora, body, quadra, it's the four bodies sitting on the back of the brain, the midbrain, okay? The corpora quadrigemina, and this whole region here, from a sagittal view, which if we go back a few slides to this view, this is the sagittal view. We're looking, here's this right here, I'm circling here. That's the sagittal view, and right now we're looking down on the back side of that brainstem, looking at, that's a inferior colliculus and a superior colliculus just on that's the right side of the brain there. But when it's cut in a sagittal view like that, but when you look at it in the sagittal view, this is called the tectum, that roof of the midbrain. Okay, so the corpora quadrigemina and the superior and inferior colliculus collectively form that tectum of the midbrain, but you only call it the tectum when you're looking at it in a sagittal view. When you're looking at it from the back, you call it the corpora quadrigemina, or specifically those inferior superior colliculi individually. Okay. Trochlear nerve right here. See this little nerve coming off right here, and it wraps around, it goes around the front. That's one of your cranial nerves for eye movement, okay? It's one of the cranial nerves. It's the only cranial nerve that exits from the posterior surface of the brainstem. So it's an interesting little nerve. Cell bodies are actually down in here, and they cross over and go out the opposite side and come out the back side of the brainstem. trochlear nerve. The fourth cranial nerve. Then we got to take a look at what happens. Remember, there's the cerebellum typically sitting back here. So the cerebellum's typically sitting back in this region here. But in order to see that back part of the brainstem, we're going to go ahead and cut that off. So we're taking the cerebellum off, and we're left with some parts where these connecting areas are that connect the cerebellum to the back of the brainstem. And those are collectively called peduncles. Remember, peduncles are like connecting stalks. Remember, we have the cerebral peduncles that connect the cerebrum with the midbrain. We also have peduncles that connect the cerebellum with the more like the pons mainly area. Okay, and we have a superior, inferior, and middle cerebellar peduncle. Okay, so here they are. This big one right here is called the middle cerebellar peduncle. So this is the middle. You have to kind of actually cut these at the right angle so that you can appreciate which one is kind of inferior, middle, and superior. This right here, this area right here, and here, that's the superior cerebellar peduncle. Okay? Then this area right in here, so that's superior. These areas right in here, this is your inferior cerebellar peduncle. Okay? So typically what happens is when you have information coming up from sensors down in your like proprioceptors in your body, because the cerebellum takes in a lot of unconscious proprioceptive information about where your body is in space for helping coordinate and balance. That information is coming up the back part of the brainstem, and most of it comes through this inferior cerebellar peduncle to get into the cerebellum. Then your cerebellum will actually send corrective signals back up to your cerebrum to say, hey, there was an error in that movement, or you need to correct your next movement. It's your next voluntary movement. So the way it does that is the cerebellum will send signals up through the superior cerebellar peduncle, up to the thalamus, then up to the cortex. So they're just pathways that the cerebellum, information gets into the cerebellum and then gets back out of the cerebellum. You don't need to know anything more than that right now. And then the other thing we want to look at back here is the gracile and cuneate tubercles. Remember, we said tubercles are just those little bumps on the on surfaces of the neuroanatomy, okay, on surface anatomy. And typically underneath those bumps or tubercles, you typically have cell bodies. You know, under the brachiums, we tend to have more axons, okay, pathways running. But under little tubercles or bumps, you tend to have a group of cell bodies under there, and you do have some cell bodies in these. These are a little hard to see. You can appreciate them on some specimens better than others. There's actually a little bump right here and a little bump right here. And there's another one right here next to it and another one right there. Well, it's a little bit farther out than that. You can see them better on that right side than the left side. It's right there. Okay. Just beneath those are so let's just talk about which one is which. So the gracile tubercle is this more medial one. So this is the gracile tubercle. And then the lateral one is the cuneate tubercle. Okay. And what you have here is there's actually information that's coming up. These are proprioceptive pathway connection points or relay centers. You have information coming up from your spinal cord that comes up the back part of this brainstem and connects in synapses in these tubercles. The ones that's coming up, there's actually this thing right here called the fasciculus cuneatus. Remember, a fasciculus is a kind of pathway or a smaller bundle or packet of typically axons. So the fasciculus cuneatus is bringing up these pathways and axons that are bringing in information and proprioceptive information actually from your upper extremities, the fasciculus cuneatus. Synapses here, and then it goes up further. We're not going to go into any more detail at this point. And then the little fasciculus just medial to that is the fasciculus gracilis, which is bringing information from the lower body and comes up and then synapses in the nucleus gracilis, which is just below that gracile tubercle, okay, that little tubercle there. But right now we're focusing on the surface anatomy. I'm just starting to kind of give you that repetition of when we get to pathways, you'll see this. You don't have to know that now, but just kind of giving you some idea about function, structure, and the function of these things. I remember the gracile tubercle and the fasciculus gracilis because we have a gracilis muscle in our lower extremity. That's how I remember that it's a lower extremity proprioceptive pathway. That's how and so then I just remember the other one must be upper extremity. So the cuneatus is upper extremity proprioceptive pathway of formation coming in through that fasciculus cuneatus and then into that nucleus cuneatus, which is just below or underneath that gracile and cuneate tubercles. Okay. Because this information actually kind of gets layered on, because what you have is your upper extremity information is coming up initially, and your upper body then gets layered on a little bit more laterally and kind of gets layered on there, and that's why the fasciculus cuneatus is a little more lateral than the fasciculus gracilis. Whew, some of those are a mouthful to say. I still struggle sometimes with those. Cerebellum. We just mentioned we got to cut that cerebellum off the back of the brainstem. The cerebellum plays a big role in coordination and movement and motor learning too. It's very essential to motor learning new movements and tasks and making them look nice and smooth. We have our anterior lobe right here, and then our posterior lobe right here. It's kind of really interesting to appreciate. You know, you look at the surface of the brain, and it has those sulci and gyri, right? So you see those convoluted folds and so forth. Do you guys know why your brain has those convolutions, or one of the reasons why it has those convolutions, what that does for your brain? I don't know if anybody's... So it's a matter of surface area. You've got an enclosed skull, so you can only fit so much in there, right? And if you want to have more area to have processing area and cell bodies to do processing, if you fold in on yourself, you've got, and then you like flatten that, if you took the brain and flattened it out, you're going to have a pretty big sheet there, a lot bigger than you would think for what it's fitting in there, because it folds in on itself, so it gives you more surface area to actually have cell bodies. Same thing with the cerebellum, but look, I mean, it's even more foliated, you know, and more invaginated with all these extra, you know, little areas here. And so that tells you just, and it's so big, and its main role is just coordination of movement. So you can just tell how important movement that, and how it's a, you know, huge task for you just to stand up without falling over is a miracle, and be able to then take steps and choose which way you want to go and adapt to your environment and make it look smooth and coordinated most of the time and learn. I mean, so that's what the cerebellum plays a big role in. So we talked about the anterior lobe and posterior lobe. That's if you're looking at it mostly from a sagittal view. However, we can from a this is a superior view right here that we're looking at on your right. There's a little bit, some you can see it better on, others there's a little bit more of a deeper crevice or fissure here that kind of separates out the anterior lobe from the much larger posterior lobe. Just, I typically wouldn't ask you a question from that superior view what the anterior and posterior lobes are, but that's kind of it there. The thing you do see from more of this either anterior, here's the anterior view here, or posterior or superior view, is you can identify what's called the vermis, paravermis, and lateral hemispheres. So in a superior, posterior, or even anterior view, you can divide it into these longitudinal sections. So the vermis is this very medial area here, okay? Vermis means worm-like, and it kind of, I don't know if it looks, you can imagine it looking a little worm-like in the middle there. Then you come out here, just past the vermis, and that's the paravermal region. And then you get out here, and these are the lateral hemispheres out here. These are much more important for us to know from a functional standpoint, because there is some somatotopic arrangement to how the cerebellum is organized in this longitudinal fashion. So more of that vermal area has to do with more coordination of areas and related to even coordinating your eyes, your speech, your muscles of your, you know, larynx, pharynx, all require coordination through the cerebellum. And also then as you get into the paravermal region, it's more like your girdle muscles and your trunk muscles. Then you get into the lateral hemispheres, and those were coordination for more of your distal muscles and so forth. So if a person has a lesion, you know, out in, say, the right cerebellar hemisphere, in that lateral hemisphere area, and it's in the right, they're going to have more distal hand, foot coordination problems on the right side. Cerebellum is interesting because its pathways are typically all ipsilateral. So remember the cerebrum we talk about most of the time. Sensory information coming in the cerebrum is coming from the opposite side of your body. Motor control is the opposite. Cerebellum is all ipsilateral. So if you have damage on the right side of your cerebellum, you have right-sided coordination deficits, okay? However, if you have damage on the right side of your cerebrum, you typically have left-sided either motor or sensory deficits. So again, we have the vermis right here, paravermal regions, and then cerebellar hemispheres out here. If we're looking, this is looking at the front of the cerebellum removed from the brainstem. And we can identify those middle inferior cerebellar peduncles here that we cut off here. So here's the superior cerebellar peduncles. This is actually the inferior cerebellar peduncles right in here. And then these out here, the big ones, are called the middle cerebellar peduncles. Okay? These inferior, a lot of times, are just a little more medial, but they tend to drop a little bit lower than the middle cerebellar peduncle. That's why they call them the inferior cerebellar peduncles. Vermis has to do more with eye and speech and those kind of things. You don't have to know that now, but you can write it down. Paravermis is more girdle, trunk, and then lateral hemispheres. So you can actually almost, there's actually a picture I think in your book that shows like a person here, their eyes, their mouth, and then kind of like, I wish I could draw. So it's kind of like this. But I'm very visual. But thank God for PowerPoint and pictures, because the person who taught me neuroscience after I got done with PT school and knew I was going to inherit this course and I was scared to death, he was super gifted. So it was really kind of a hard act to follow. So he started when I taught at Andrews University, he taught our students for a few years. He actually would travel down from Michigan to do our neuroscience course. And then eventually he said, Kurt, you're going to have to take this over. So I sat in on his course for several years to kind of learn. And he just had plain old black and white handouts, and he was old school, never used a PowerPoint, and he just had a whiteboard, and he would draw all this stuff out just perfectly. It was just amazing. Actually, John Banks, he is one of the authors of your anatomy text that you guys use. John Banks is one of the ones that did that. So, yep. All right. Can't leave out good old Atticus, I guess. He's a crazy cat. Found him. Our cat passed away just like a month before we found this cat. Of course, we went down to the bike path. My wife and I let's go down the bike path, go for a ride. And literally within like a couple hundred yards of starting our bike ride, there's this crazy cat, this little kid, sitting right in the middle of the bike path. Somebody had dropped him off there. They put a little cat food in the middle of the bike path just to get him to kind of stay there, and they bolted, assuming that somebody would probably come by and find this cat. And so we were the first ones to come upon him, and like timing, destiny, all that stuff. Of course, I was the one who wanted it more than my wife did. But so, because as soon as I petted him, he would not leave. We go, let's just see what happens. Let's go down the bike path. We come back, he's still there. Maybe we'll. But he just followed us. He would not. He just ran. Poor kitty. He was all out of breath, and so. All right. Spinal cord, real quick. So we're moving down. We talked cerebrum, brainstem, cerebellum. Now we're in the spinal cord. Lies within the vertebral column, okay, spinal canal, the vertebral column. Here's a key thing. It ends at L1, L2. It doesn't go all the way down to the sacrum, okay? So the tip of the spinal cord ends L1, L2 in the intervertebral disc area, right between those two vertebral levels. It has this thing called the cauda equina. So where that tip of your spinal cord ends, there's a bunch of nerve roots that come off to go down to your lumbar and sacral nerve roots. It's called the cauda equina, which is a horse's tail. It looks like kind of a tail. There's this little structure that anchors your spinal cord from the tip of it down to the sacrum called the filum terminale. It's actually an extension of one of the coverings of your nervous system called the pia. So then the pia mater comes down and has a little extension of cells and forms this little fiber that goes down and kind of anchors your spinal cord to your sacrum. You have dorsal roots and ventral roots that go into your spinal cord or come out of your spinal cord, okay? Dorsal roots are afferent information. So when your spinal nerves bring information back to your spinal cord, they go in through the back door, okay? They go in through the dorsal roots. That's the sensory information comes into the back part of the spinal cord, okay? The motor stuff goes out the front door. It goes out through the ventral roots, okay? These dorsal and ventral roots join up to form the spinal nerve, and then you get that mixed nerve, which has both motor and sensory information, but there's also some autonomic in there too, okay? Especially in those thoracal lumbar segments that have sympathetic autonomic function also intertwined with them to go supply blood vessels, sweat glands, all that kind of stuff. You got 31 pairs of spinal nerves. You know that stuff already, the numbers on those. This is just showing you a sagittal view through the spinal cord. Here's the tip down here, ending between that, you know, L1, L2 region, okay? This is looking at a frontal view here, and you see this is where the tip is here. This whole area here is the cauda equina. So you got a bunch of those nerve roots coming off the very end here to go supply the rest of the lumbar and sacral segments. You have a little bit of an enlargement here because you have more nerve roots coming off there, so there's actually more cell bodies in that, so it's a little bit enlarged. It's called a lumbar enlargement. So the lumbar spine down there is a little bit bigger, okay, that L1, L2. And then you have a cervical enlargement up here. That's a little bit bigger, just because there's more cell bodies in there. You've got more sensory information and more motor information going to all these little muscles of the hand, forearm, and all that stuff. So the spinal cord is a little bigger up there. But that also compromises space a little bit. So if you've got some stenosis and narrowing of your spine and arthritis poking in there, that's why it's common to have cervical spinal stenosis, because the spinal cord's bigger there too. So there's less space in there to accommodate if you've got a disc bulge or something infringing upon that space. This is actually a cadaver section, and we can do this. Have you guys done a laminectomy, like all the way down and chipped out the spinal cord? It's kind of laborious, but this is the spinal cord, and it's been opened up, and there's actually dura. There's a covering that covers your spinal cord, brain, cerebellum, the dura, and there's arachnoid and pia. There's 3 layers that kind of cover all this stuff, but that's been opened up and removed here. And you can see some of the nerve roots coming out at different levels, but this is the cauda equina sitting in here, okay? All these little fibers there. And there's a little lighter colored fiber right here, just a little bit lighter, that I'm kind of starting to trace up right now, and it goes right through there. That's the filum terminale, okay, the filum terminale. That anchors that end of the spinal cord down into the sacrum right down here. Looking at a horizontal section through the spinal cord right now, just quickly looking at a horizontal section through the spinal cord. So we just take a brief look at the internal anatomy. We have gray matter and white matter, just like we have gray matter and white matter in our cerebrum and even in our cerebellum, okay? We have gray matter and white matter in our spinal cord. Uniquely, in the spinal cord, the gray matter is in the center and most of the white matter is on the outside. In our cerebrum and cerebellum, most of the gray matter is on the outside, most of the white matter is on the inside. We do have some few, like the basal ganglia nuclei, some gray matter spots inside of our cerebrum, but in the spinal cord, it's pretty well laid out. All the gray matter is kind of in the middle, all the white matter is on the outside, okay? So the H structure in the middle there is the gray matter, and it contains cell bodies, and it makes up what's called the dorsal and ventral horns, okay? So here's the ventral horns, and this is the dorsal horns, okay? We have a central canal. There's a little canal right there that's where you can't see on this particular slide, but it's not like a big open canal all the way down, but there's remnants of a central canal down through there in some areas, especially in the cervical spine. That canal is more prominent. You lose it more as you get lower, okay? In the thoracic spine, there's also what's called a lateral horn. You only have that in the thoraco and upper lumbar spine. That's actually where some cell bodies for your sympathetic nerves are located. Okay, you don't have that in the cervical spine. You do have, I should take that back, you have some lateral horns in your sacral level, which isn't in your sacrum, it's down, it's in that tip of the spinal cord at L1, L2, but where the sacral segments come out, there's a little lateral horn there for the parasympathetic neurons, cell bodies, the sacral division of the parasympathetic nervous system. So if you see lateral horns like this, you know you got to be in a thoracic level or a sacral level. You know you're not in a lumbar or a cervical level if you see little lateral horns on there. Okay. But the dorsal horns, this is where, remember we said afferent information comes in through the dorsal root. So it comes in and usually makes a synapse in here, and there's some cell bodies in there, and then they do things like cross right over and go up the other side of the spinal cord. Sometimes they come right in and go right up the back part of the spinal cord, but that's what the dorsal horns are for, is for sensory information coming in. That's their initial stopping or junction point for a lot of that coming in. Versus the anterior horns, this is where you're sending information out, efferent information to motor structures, okay, through the anterior root, okay. The dorsal root and anterior root join up together to form the spinal nerves out here, just before they exit out of the spinal column. They come together to form the spinal nerves. They're mixed, okay? And then remember, we always have in the thoracolumbar area some autonomic fibers thrown in. So autonomic fibers also go out that ventral horn and get mixed in there, so into that mixed spinal nerve. And when you have a big disc bulge, a lot of times the disc bulges and actually hits right there where those come together, the two spinal nerves. And so you get that mixed presentation. If it's a big enough disc bulge, it can cause both motor and sensory loss because the nerve has come together there. You're not just affecting the anterior root or the dorsal root individually. Sometimes you can, and you can get more motor and more sensory deficits depending on how things are pushing on that spinal cord around it, okay? We have the white matter now is these big columns here. So here's this one, we have this one, and this one. So we kind of have these posterior, lateral, and anterior columns of tracks of information coming down or up that spinal cord. It's like they're conduits, you know, for information. And those are, again, mainly axons we're talking about there. Remember we talked about like a fasciculus is a little packet or bundle, a funiculus is a bigger packet or bundle. Some people refer to like this big area out here as the lateral funiculus of the spinal cord. The back part here as a group is called the posterior funiculus. We're going to typically call it the dorsal columns, okay, is what you typically hear it referred to. But some people will refer to that as the posterior funiculus, and they'll refer to this as the anterior funiculus of the spinal cord, okay? But we're going to refer to like dorsal columns, and you can call it dorsal columns, lateral columns, or anterior columns, or funiculus, or a funiculus. Those are interchangeable. Another horizontal section of the spinal cord, but as it sits inside the spinal canal, so you get a better appreciation for where it's sitting in that spinal canal. So here's your, you know, lamina back here, the vertebral lamina, and then here's your front part of your vertebrae there, okay, the vertebral body. And so here's that dorsal root we were talking about. Sensory information comes in there, then it comes out here. Here's the anterior root. Then they come to join together here as a mixed nerve. This is a thoracic. We have a little lateral horn here, so there's little autonomic fibers that also go out here. And then once you get out of here, you divide into a, we call a ventral ramus and a dorsal ramus. Don't have to know that now, but you got to go supply the back side of your body with motor and sensory. That goes out to the dorsal ramus, but then all the rest of this goes out to the front side of the body through the ventral ramus, okay? And then here's your big disc right here. Most of your discs bulge posterior and lateral, and they go and they hit right there in that area that is compromised as it exits out the little foramina, as it exits out that hole. Okay, that's also where you can get some arthritis, some lateral foraminal stenosis, that it causes some narrowing of the hole as those nerves, spinal nerves, are exiting out the sides. So if you get narrowing here, like arthritis and little osteophytes that pinch in here, that's kind of a lateral foraminal stenosis. Some people get osteophytes and arthritis here in their vertebral body, and it pushes and closes off the center. That's a central stenosis. Okay, we call it central stenosis. Central stenosis is if they get bad enough, or actually worse than lateral stenosis is, because you can actually shut down spinal cord function, okay, versus just more of a peripheral problem. You can actually cause some central nervous system problems.
Are the roots, like the dorsal root and stuff, are they made up of both gray matter and white matter?
Good question. No, they are, well, they're white matter, the axons, except there is a little ganglia right here called the dorsal root ganglia, where sensory information comes in and makes some of their connections right here in the dorsal root ganglia before it goes in the dorsal root. So there's a little bit of gray matter right here, but most of these are just axons going right past that, okay, or coming in past that, okay. I should say that. Most of them do actually synapse here. So it's white matter. There is a few cell bodies in here, and then then white matter through here. So this dorsal root part, till you get to the dorsal root ganglia, this is all axons. But there is some gray matter right there. So quickly, coverings of the nervous system. So the nervous system has these coverings on it. I've already mentioned them a few times. We have the outermost layer, which is the dura mater. Literally means tough mother. Dura mater, tough mother. Okay. It's the outermost membrane. It makes up a few significant structures that we can see, feel, touch. The falx cerebri, that's where the dura mater goes down in between your cerebral hemispheres, called the falx cerebri. It forms the tentorium cerebelli. It's the tent. It's the little, dura mater comes in and kind of forms a little tent over the cerebellum, in between the cerebellum and the bottom part of the cerebrum. Okay, and then it also forms the dural venous sinuses. So these are like big drainage ditches. When your venous blood eventually from your brain gets into these drainage ditches that are formed by dura and just dumps it back into your venous drainage, okay? It eventually gets to your jugular vein and drains back into your system, okay? The next layer below that is called the arachnoid layer, okay? Spider-like, and when you look at it, it looks like spider webs almost. Kind of looks a little fibrous and spider webby over the top of the, so you take the dura off, and then you get this other layer, and it feels like almost gelatinous, because underneath the arachnoid is where the cerebral spinal fluid flows, okay? So there's usually some cerebral spinal fluid left in there, and you have to kind of pull it off, of the brain surface once you take the dura off. It forms the subarachnoid space. There's a little space between the arachnoid and the brain tissue and the pia, where this little, couple millimeter layer of cerebral spinal fluid flows through there. Okay, and then we have the pia mater, which is delicate mother. The pia is delicate mother. It is a delicate membrane of a microscopic thickness. Okay. That is just a couple cells thick, that lays right on top of the cortex, okay? So this little layer, you can't see it. It's not visible per se, but it becomes visible at the end of the spinal cord when there's enough of them that come together to form that filum terminale, okay? This is looking at a little cross-section, like at the top of the skull here. So here's the bone, here's your skin, okay? But then you have this pink layer is the dura. It's real leather-like. I mean, it's tough. It's like beef jerky. I mean, it's really tough and sinewy, okay? Then here's the arachnoid layer, and it's got these little end feet that like kind of give that, and that's what helps hold it up and give that little space for cerebral spinal fluid to flow in that little tiny space. It's flowing around all through there. And that arachnoid surrounds your brain, cerebellum, brainstem, spinal cord, and that's how it gets. Remember, the cerebral spinal fluid gets out into that area through the bottom part of your cerebellum. It's made in your ventricular system, and then it gets out and flows around. You'll see a picture of that in a second here. Here is some blood vessels. Most of our surface blood vessels for the brain lie in the subarachnoid space as well. So if we talk about like something like a subarachnoid hemorrhage, if there's damage to one of these arteries or blood vessels in that subarachnoid space, that causes a subarachnoid bleed. And they'll actually do, if they think you have a subarachnoid bleed, they might do a test of your cerebral spinal fluid. They'll tap your cerebral spinal fluid in your lumbar spine because you got a nice big space in there to do that. Below that where the tip of your spinal cord ends, you've got an area where they can stick a needle in there and not going to hit anything. I mean, it might hit a little nerve root or something, but nick it, and that you recover from. But they'll look for blood in your cerebral spinal fluid because if you've got a subarachnoid bleed, blood gets in your cerebral spinal fluid, and they'll look for that. Of course, they can also see that on MRI nowadays pretty easily. So, and then the microscopic layer right here, this real thin layer right on top that's attached to the cortex here. Here's our cortex layer here, is the pia. Those are your three layers. They provide support and protection to our nervous system. So this is the backside of somebody's brain here, and typically there's a covering. There's a covering all over this. And there's actually a brain specimen in the lab back there that we left, or Kim Ritteroff left all the dura on top of it, got it out with all the dura. So what we've done here is cut away the dura for the most part, and what's left is where the dura goes in and kind of dives down into the crevices. And that's this right here is the falx cerebri right here. Let's change this to yellow here. Falx cerebri right in here. This right here is the tentorium cerebelli right here, and you it's almost like a tent-like shape there. There's the tentorium cerebelli. And those go all the way in, and those crevices deep in there. Here's from a sagittal view, looking at a midsection, okay, mid-sagittal view here, right through the center, and then what we've done here, the previous pictures you've seen, this is the falx cerebri that's sitting here. That's normally we've pulled that out or taken it away so you don't see that in there anymore. But it actually dives down in there, and then this is the tentorium cerebelli right here, and it actually comes up this way too. It's been removed here when we did the cut through that, but you can see that's all dura there. This is all dura here. That's all dura that surrounds this whole nervous system, okay? And then you see those little subarachnoid spaces here where there's some gaps and spaces. Real quick, blood supply, just kind of major blood supply here. So now we're moving into that. We do need to get blood to our brain, obviously, and it's got to be constant because we don't store glucose in our brains, so we don't have any storage, so it's got to be constantly fed, oxygen and glucose. We get that via two main things. We get it through the internal carotid arteries and the vertebral arteries, okay? The internal carotids provide it to most of the front part of your cerebrum, okay? Biggest part of your cerebrum, especially the front part of your cerebrum. When the internal carotids come up to supply that cerebrum, they divide into two major vessels. They divide into the middle and anterior cerebral arteries. The vertebral arteries, okay, which are coming up in a different region, okay, in your spinal cord area and in the front of your vertebrae, they come together to form what's called the basilar artery, and then that goes up to supply what's called the posterior cerebral artery, and that supplies that back part of your brain, inferior and back part of your brain, as well as the cerebellum and the brainstem, okay? So we'll show you a picture of that in a second. And then we have the dural sinuses. This is for venous drainage. So the blood's got to get out of there, and there's some deep veins in the brain, but most of it's drained out through these dural sinuses that are made out of dura. They're not true blood vessels or anything like that. There are some deep veins, but they eventually dump into these sinuses, okay? So here's looking on your left is looking at an inferior surface view of the brainstem and inferior part of the cerebrum there, and we're just looking up, and we've got a few cut ends here. Here's the cut ends of the internal carotids. The internal carotids are coming up, and they've been cut off there, and they come in to supply most of the front part of your brain, okay, top and front part of your brain here. They divide into this middle cerebral artery, which dives in here, and then the anterior cerebral artery, which comes up here to the front part, okay? So it's internal carotids. And then here's the vertebral arteries coming up, that coming up on each side, and then they join to form the basilar artery, which then eventually terminates and divides into two posterior cerebral arteries. And they're going to supply this inferior and back part of the brain, and cerebellum and brainstem. It's got these little basilar branches that supply the front part of the pons and the brainstem, and then some parts that come off the vertebral arteries that supply the inferior part of the cerebellum. So don't have to know the detail on that, just know vertebral arteries, internal carotids, okay? And kind of generally where they supply. So here's a fun one. Here's a picture on an actual specimen that's actually been colorized to make it even easier for you. It's still not that easy, but here is one of the cut ends of an internal carotid right here, and the other one is kind of right here. So they've kind of gotten moved around a little bit, but those are the cut ends of the internal carotids. They divide into this is the middle cerebral artery coming here. There's an anterior cerebral artery coming up here, another one you can see barely right there coming from here, and then the middle cerebral artery is diving in this way, okay, from the internal carotid. Here's your basilar artery. Here's one of your vertebral arteries here, and it's been cut right here, and there's another vertebral artery right here, it's been cut right there. They join together, and then here's those posterior cerebral arteries here. Lots of stuff in here, you know, around those cranial nerves and all that vital areas, okay. Aneurysms are common at these little bifurcation points. If you see these places where you get little bifurcations and it divides, is a common place to have little aneurysms and so forth. Real quick, ventricular system. So we've mentioned this again. This is with a cerebrospinal fluid system. So inside of your brain, you have these ventricles, okay? And this is, again, three-dimensionally, like how do all this crud fit in there, you know? These ventricles, these thalami, the basal ganglia structures. So you see how those ventricles are kind of C-shaped like that? Well, fitting in here, and you see that little hole right there? That's the interthalamic adhesion. Interthalamic adhesion goes right through the middle of the third ventricle. But so you basically have, first of all, you have a thalamus on each side right in here. And then you come out a little more lateral and you've got your basal ganglia structure sitting in here, and the ventricles wrapping kind of around it, okay, is how that kind of works. What does it do? It's a regulation of extracellular fluids and protection of the CNS, so it gets to the outside of the central nervous system. It's formed by what's called choroid plexus. There's a couple places. Why isn't that showing up as I'll just see if you can see that. There's a couple places in the ventricles where you have some little choroid plexus that is basically, it filters your blood, and it's almost like a plasma, you know, that you get the clear cerebrospinal fluid formation from, okay? And they've got some on the floor of the fourth ventricle, a little bit in the roof of the third ventricle, and that's how you basically get your cerebrospinal fluid mazes. Is basically a filtration system there that filters your blood to create that clear cerebrospinal fluid. So we have the two ventricles. We have a lateral ventricle on each side of the brain, in each hemisphere. There's a little junction point here that connects each of those lateral ventricles with this area in here, which is your third ventricle, okay? And your thalamus on each side and your hypothalamus form the walls, the lateral walls of the third ventricle. And remember, it's just this little tiny sliver of a space. And then you have a little cerebral aqueduct which goes down through your midbrain and then into this space here just behind the pons called the fourth ventricle. And then eventually it comes out, so there's three different openings that it comes out below and to the sides of the cerebellum. There's one in the middle, inferior middle part of the cerebellum, and a couple, two on the sides that it exits out to get into that subarachnoid space and start to flow around everything on the outside. It's constantly circulating. There's another way for it to drain back into the dural sinuses. So your venous blood drains in the dural sinuses, but so does your cerebrospinal fluid gets into the venous sinuses to all get recycled, okay? All right, let's wrap that up here, the introduction overview. So, clinical application of neuroscience. What do we hope to get out of this course, and how do we hope to apply this stuff? This is where you need to be able to use this information to understand the effects of various nervous system lesions. So if you have got damage in a certain location, what are you likely to see? Now, you're not a neurologist, you know, you're not an ER physician with that, but you should know. I think it's, and a lot of times it's even more important as a physical therapist, at least to know what to expect. You might see is that, you know, if you look at the MRI report, you kind of look at their medical history, you're going to expect these particular deficits, but it's never cut and dry. It's never textbook. You know, you're always just going to go, this is what I'm likely to see, but I'm going to take what I get, but I'm prepared for these deficits, okay? Or if you see somebody you're treating and they start changing over time, and you really like, should I get this person back to their physician? Am I seeing neurologic changes that I can identify and I can make sure I can get them back into the care they need? And that's where we get to understanding some of the basic differential diagnosis and when to refer a patient. We talk about lesions, general categorization of lesions. We have what we call focal lesions. So these would be like a small tumor or a stroke that are more focal in nature and kind of, you can kind of define the borders of it. So you can kind of say if it's right there and we have defined borders, these are likely some of the deficits you might see associated with that. If it's a multifocal lesion, those are things where you might have more than one lesion. So if somebody has a tumor that's metastasized and has got more than one location, that's something that you need to look at and can cause deficits in those locations. Harder to narrow it down. Multiple sclerosis is a good is the you know, prototypical multifocal lesion. You've got all these white matter lesions that can occur randomly throughout the cerebrum, brainstem, or spinal cord. So that's why MS is a challenge, but it's also very interesting to treat because they're so varied, the deficits you might see. Then you have what we call more diffuse degenerative type things, Alzheimer's disease. It diffusely affects wide regions of the cerebrum, okay? Bacterial meningitis is going to affect large regions because of the meninges. The meninges are if you talk about the meninges, that's the dura, arachnoid, and pia together. Those three layers are called the meninges, okay? And you get bacterial infection within those layers that can cause diffuse problems. Is that it? No? There we go. So what causes lesions of the nervous system? So trauma is a big one. Any type of trauma, any type of vascular disorder, whether that's a bleed or a blockage, okay? Any kind you interfere with blood going downstream from that to that part of a region of nervous system, it's going to cause a problem. Any kind of inflammation, okay? Degenerative diseases, neoplasms or tumors, immunologic, okay? So, or toxic or metabolic, so like manganese poisoning, carbon monoxide poisoning, those kind of things. Those can all influence and cause nervous system lesions. When we're doing a neurologic exam, a couple things just to think about is history. History is huge. You get most of your information from your history. You know, before you ever get your reflex hammer out and do your testing, you can usually come up with a pretty good guess of what's going on before you ever do a physical exam. Physical exam just hopefully confirms what the history is telling you. So things like the acuteness, did it come on right then? Like you noticed symptoms one moment and you had them the next, or did it come on slowly over time? Those are some things. Does it wax and wane? Does it come and go? Those are things that are really going to tell you a lot about progression and those kind of things. Does it affect mental status? If it affects mental status, you know it's got to affect frontal lobes. If it's causing mental status problems, you know you're talking a cerebral problem that's affecting some of your frontal lobes. Then we do our examination, which are our specific motor and sensory tests, which you'll learn. We'll review again some of those in this class and get a chance to get that stuff out again and play. And then you hopefully come up with a diagnosis. Or the physician comes up with a diagnosis, but you at least are able to say, yeah, that diagnosis fits what I'm seeing. And because oftentimes you're seeing these patients more intimately, longer. You may be picking up on things that the physician didn't pick up in their 10 or 15-minute visit that you go, ooh, this is not matching what that physician diagnosis said. I need to maybe give that physician a call. Let's talk about it. In your book, your Crossman book, I don't have it, it's down here, but anyway, in your Crossman book, let's see here. As you go through the chapters, it'll give you some little things like where it'll show a diagram of a little man like this with some little pluses and minuses and different coloring, but it'll also show you some pictures of, on the side here, you'll see it'll show actually, so here's the picture of the guy here, and on the side is a little schematic of the nervous system. It has the brain, brainstem, and spinal cord on it. And if you learn kind of what these mean, it's really nice. It's a quick reference to see if you have a lesion at a certain location in the brainstem or in the cerebrum, and then what are the deficits it'll tend to cause? Motor, sensory, reflex, and coordination-wise. So then it gives you, and we'll just point that out. So if you see a little key like this where it shows, so it shows your cerebrum, shows your cerebellum, shows your brainstem, and your spinal cord here, okay? This is normal. So this is what a normal looking schematic would look like for this textbook. Nice and gray, everything's plump, everything, all the structures are there. But if you have, then it'll show you what it would look like if you have a deficit or a problem, okay, or where the location of those problems might be. And so on the one on your right there, you'll see is it'll show you like Alzheimer's disease right here will affect the cerebrum, okay, and so you know that Alzheimer's is primarily a cerebral disease. Huntington's disease, you see it pointing to this basal ganglia. It's actually a basal ganglia disorder. Lobar atrophy, which is just another form of degeneration and atrophy of the cerebral lobes. Parkinson's disease, you see it pointing right here to the middle. It's a midbrain problem. I should change my color. And I can't get my little thing to come up. So there's a midbrain problem is what that's showing you, okay, when we get to Parkinson's disease. Friedreich's ataxia happens to affect some of the pathways in this region that connect to the cerebellum. Cerebellar ataxia, see it's pointing to the cerebellum. Motor neuron disease, degeneration of the motor neurons going to your muscles. So it's pointing to the locations where they have the problems. But in some of the pictures, they'll show you the degeneration, like you might see a little extra atrophy of the cerebral hemispheres and those kind of things. So just wanted you to know what those pictures mean and pay attention to those. And then here are the pictures of the individual that they use a lot of times to kind of give a key. This is somebody who's normal. So normal, they have no coloring. They have just, if they just show these 1+ sign here, that's all normal reflexes. That's indicating normal reflexes. The little arrows going down, that's indicating a normal Babinski response. I don't know if we talk about Babinski where you scrape the bottom of the foot, your toes typically point down when you do that. If you have a problem with your nervous system or central nervous system, they often then want to go up. The big toe goes up and they splay out. So that's showing a downgoing. That's a normal downgoing response. Sensation, there's no coloring in here, and motor also right here, there's no coloring, so they're not indicating any problems with the motor sensory system. And then this is coordination. They're showing nice straight arrows when they move their limbs, that there's no shakiness or coordination deficits. But if you have somebody who's had a stroke, so what they're showing here is, so here's our little schematic on your left of the nervous system. They're showing you where the lesion is right here. Here's the lesion up in the cerebrum. And it's in the cerebrum on the left side of the cerebrum because they're facing you this way. So it's a left-sided lesion, right? So it's a left lesion right there in the cerebrum. So this is the problems it's causing. Since this is highlighted in red, this is motor weakness, okay, on the right side of the body. It's a left-sided lesion. He's got right-sided motor weakness, and it's actually showing a common pattern that they tend to go into and adopt with a stroke, with a upper extremity flexion, lower extremity extension, okay? They also say they might have some aphasia, problems with speaking, because this is a left-sided lesion, that there might be some aphasia. Their reflexes are going to be heightened, typically, on that right side as well. They're going to have a Babinski reflex that's upgoing when you scrape the bottom of their foot. Sensation might be impaired in the entire half of their body. They might have lack of sensation, depending how big that lesion is in location. And then their coordination will be impacted. They'll have difficulty moving their limb in a coordinated fashion, both the leg and the arm on that side. So that's what those diagrams and how you kind of read those diagrams and get a quick picture of what they're trying to show you. So I like those. That's why I love, this is the one that would sit on my desk at work and be able to go quickly, all right, they're coming in 10 minutes, they got this diagnosis, what am I expecting to see, kind of lesion-wise and deficit-wise, all right? Beautiful. Finish that up in an hour. Questions on anything? Jenna?
I'm wondering kind of how to study for your quizzes and exams.
Yeah.
Do